Welcome to Cracking Cancer, where we tackle the tough questions about cancer with real patients and world experts. Our mission is to empower the cancer community through education, bring transparency to the oncology system, and drive funding for critical cancer research. Whether you're facing a diagnosis, supporting a loved one, or simply here to learn, we're here to bring clarity, hope, and action to the fight against cancer. Hey everyone, welcome to Cracking Cancer. Today we are going to be tackling the question of what is prostate cancer. I'm your host, Dr. Kyle Concannon, physician scientist at MD Anderson Cancer Center. And joining me today are two experts. We have Dr. Justin Lebenthal, the academic expert here, and then we have Tim Fitzgerald, the experiential expert. Maybe you both can jump in and introduce yourself. We'll start with Fitz.
Well, I am Tim Fitzgerald. I'm 61 years old. I was diagnosed with prostate cancer in 2018 at the age of 53. I am metastatic stage 4. I've beaten my odds. And I continue to work full time as covering Kansas State and Big 12 athletics for 24/7 Sports. And I have my own summer podcast called The Life of Fitz, where I discuss my cancer and have guests on that talk about overcoming obstacles. Last one was about a coach who got abruptly fired for reasons hard to explain and how it affected him and impacted him and moved on. So I talk about a little bit of everything. It's really about overcoming what's in your way.
Well, thanks for joining us here today. And looking forward to learning how you've overcome your odds with prostate cancer and some tips you have for others. And Justin, tell us a little bit about yourself.
Kyle, thanks so much for having me today. And Fitz, thanks for being here as well. I'm Dr. Justin Lebenthal. I'm a GU genitourinary malignancy focused medical oncologist at NYU School of Medicine in New York.
Awesome. Well, thank you both. And, to jump right in, the topic today is prostate cancer. So Justin, to you, can you explain what prostate cancer is, where the prostate is located, and what the prostate normally does?
Absolutely. So the prostate is a walnut-shaped gland that sits just between the bladder and the penis in front of the rectum. And its usual function is actually mostly reproductive. It helps make some of the fluid that goes into semen and help with fertilization and things like that. So you actually don't need a prostate to live. Prostate cancer is when the prostate cells themselves start growing uncontrollably and can either grow outside of the prostate itself or spread away from the prostate.
Okay. I think that's a pretty clear description. Is the process of prostate cancer forming different from other cancers, or is it similar, in how cancer happens or how we should think about it?
Yeah, so and most of the time, we don't know exactly why men get prostate cancer. It's, there are some high-risk populations, as we age, we accumulate more mutations. And so it's definitely a disease that occurs mostly in older men. But in general, it's not thought to be a hereditary cancer or something that's passed down, but only about 5 to 10% of cases do have some sort of gene that can be identified that is passed down from generation to generation.
Okay. And you mentioned mutations. I work in mostly lung cancer. People smoke, the smoke goes into the lungs, it causes mutations. In my mind, that's a pretty easy cause and effect to wrap my head around. Is there something similar in prostate cancer, or, is that in the bucket that we sometimes see in lung cancer too, where we say this is just bad luck, this mutation just happened randomly, we don't really know why?
Yeah, it's mostly just bad luck, unfortunately, for some of the acquired mutations in the tumor itself. The mutation, the most common one that's passed down is actually BRCA mutation, which, most notable in breast cancer, but is also can be part of a risk factor for prostate cancer.
Okay. So if someone's mother or other family member had one of these cancers, or breast cancer, and I know BRCA is associated with some other cancers too,
Right.
A reason to tell their doctor about, hey, I might be at higher risk for even prostate cancer.
Yeah, definitely. So BRCA can put you at risk for breast cancer, ovarian cancer, pancreatic cancer, or prostate cancer. So definitely, if that any of those occurred, the family history, it's important to let a physician know.
Okay. So, over to Fitz, can you describe how someone might first find out that they have prostate cancer?
You'll start to notice some differences, and they're all a little bit different for each man. And mine was leakage that I attributed to obesity because I weighed 90 pounds less than I did at the time of diagnosis. I was grossly overweight, 353 pounds, and so I just attributed that to being fat, but it wasn't. And it had come on pretty quickly, which should have been a clue. But I didn't even know what a PSA score was when I was diagnosed. I mean, when I came down with it, I had back-to-back insurance policies that people gave me labs, and sure enough, my PSA went up a full point in 2 weeks. Grace of God, we caught it. But yeah, I knew right then. I connected the dots, and I decided to become an advocate and talk about everything related to my prostate cancer. And I mean everything.
Well, thanks for being so open. The first thing you mentioned, leakage. I want to be like just crystal clear when someone's listening. What do you mean when you say leakage?
Excuse me, urinary leakage, and honestly, it happened most frequently. When I would consume alcohol, you just kind of get less attention to you're holding your bladder, and that's true to this day. A big reason why I don't drink very much anymore. But yeah, it was notable, and it was confusing. It was like, what's going on here? But not enough to get me to the doctor, apparently, which is, I think, a genetic trait of most men.
Yeah, we see that a lot with the pesky Y chromosome. So when, just to elaborate on that a little bit, would this happen when you had like a distended bladder, like you were drinking a lot of fluids, and you're sleeping and a little bit comes out, or,
No.
What did that really look like?
It would entail I get home and realize the front of my jeans are a little bit damp. Did I spill? And then when it kept happening, I realized, I'm leaking, and that's not fun. But it wasn't noticeable. It wasn't like wetting. It was just kind of dampness. So I just kept going. And that was a mistake because, as it turned out, my prostate cancer was highly, highly aggressive. So I literally mean it. We were very, very lucky to catch it.
And was that leaking happening every day or once a week?
2-3 times a week, and it would happen also with physical strain. So
I see.
And it was an indication that my prostate wasn't functioning correctly. Justin talked about the role of the prostate. When we're little boys, we're training our prostate when we learn how to control our urine. And so when that falters, our mind can't reset that very easily. So it took me a while to realize that there's something going on. And once I was diagnosed, it's like, okay, this all makes sense now. But I was not thinking one iota about prostate cancer. And my prior physician was a 55 and older tester, which is, I believe, a very dated barrier. I think it at least should be 50. I'm an advocate for 45, certainly if you have family history. Just to get that baseline score. I had no baseline score. I had never taken a PSA test until those 2 insurance agencies sent a lab to my house.
Jeez. And was the urinary leakage your only symptom?
In hindsight, there probably were other things, but that was the majority one. Because for a guy, wetting your pants is pretty personal.
Right.
And I think there probably were things, but again, it was all muddled up with obesity and maybe there was exhaustion, probably because I was fat, but maybe it was some of that. You just deal with it. You got the information you got, and boys, I didn't have enough information.
Well, and you were in this position where, a lot of things can potentially cause some urinary leakage, and many of them are non-life-threatening. So, for a betting person, a little bit of urine dribbles out every now and again. Most of the time, it's probably not going to be a life-threatening thing, but that lulls us into this sense of security, which I think a lot of guys do, which is like, I'll wait till there's really pain, or like, let's look at this get a little worse and see what happens. And I think that's a challenge that many people fall into, particularly in cancer, because you can always remember back when the symptoms were more subtle, but it's not until things progress a little bit that you realize, oh, this is something that's really bad. And many times that delay can lead to the cancer having spread. And there's a lot of guilt around that. People feel really guilty when they look back and they say that symptom might have been when this was curable. Is that a feeling that you were having looking back?
That's very true. I maybe did that early on, but cancer changes you, and it's changed who I am. One of the weird things I tell people that freaks them out is cancer made me a better man, because it clarifies, it makes you realize what's really important to you. And looking backward doesn't serve me any good. Keep going forward and just worry about today, because when you got cancer, it's easy to worry about a lot of things down the road, including test results, which every cancer patient will tell you that. That's not a prostate cancer thing. That gap between taking a blood test or whatever test and getting the results is nerve fraying. But yeah, you got to deal with what's in front of you, because you can't undo what's behind you.
Yeah, thank you for saying that and articulating that so clearly, because everyone that I talk to has guilt somewhere along the way. And that's something that, even being the host of this podcast and meeting other patients who are going through this, Justin, maybe you can speak to this too. When we're in the clinic, we're pretty focused on objective measures and like things like scans, things like what do the labs look like? How are you objectively feeling? You haven't pain anywhere. Sometimes my ability to detect someone's feeling of guilt and those subjective things that help them positively experience their life, which is the whole point of a doctor, is to like get you well enough to live a comfortable, happy life. That falls by the wayside sometimes because we have all this other objective stuff. Justin, is that something that you experience in your clinic?
Yeah, definitely. I mean, it's hard given how much information we need to relay to our patients and how much counseling we want to do based on where's the cancer, the treatments, the side effects, really our checklist. But I make a point, regardless of how much information I have to tell the patient, I always start out with an open-ended question. How you doing? What's new? How you feeling? What's on your mind? Something like that. So that they feel they have a space to talk about what maybe is on their mind that nobody asked about, or a question that I didn't know to ask, before we kind of delve into the nitty gritty of what's going on with their disease. So I make a really contrived point to try to keep things broad in the beginning and then focus based on their body language and the answers they give.
Yeah, I think one of the things that allows that conversation to happen is the rapport that people have with their doctors. And I think there's a stigma in oncology, particularly that oncologists can be kind of cold. They can be, a little calculating. We look at the numbers, we look at the data, we look at the scans. And, Justin, you're someone who I wanted to have on because I know from having trained with you how you make that experiential connection, the doctor-physician relationship is really important to you. What are some of the things that you do to help foster that open-ended question at the beginning, make someone comfortable talking to you?
Yeah, honestly, it's really simple. It's asking about their life. The social history that we learn in medical school often gets neglected, I think, as the time we become attendings. But it's really very important for treating a patient with a chronic disease and illness, especially cancer. I have to know who's going to be able to support this person. I also have to know the things, their hopes and dreams. What do they enjoy doing? How do they spend their time? And so just asking the simple, what do you do for work? What do you do for fun? Do you exercise? Things like that. And just asking those things, and also incorporating family members whenever I can. After that open-ended question, as soon as I start asking, or rather kind of giving information about our plan or any sort of scans or any sort of lab work, I say, is there anyone you want to call? And then I get to know their family through that. And, then I can ask how, so-and-so is doing when I see them. And it creates a sense of familiarity and comfort for them. And is, I think, important to being able to actually treat the whole patient in front of you, and not just the disease and not just the diagnosis, but actually the person in front of you.
Yeah, that makes total sense. And I think the ability to bring in family members to understand who is the care team around that person
Yeah.
is really important. Fitz, over to you. Who is, your care team? Who are the people around you that you bring in, or do you go to your visits, mostly with yourself or by yourself?
Both. I want to say one thing, Justin. You just described something in the media we learn about interviewing. You give them some easy questions, give them some stuff, warm them up, get them talking to you, and then come at them with, this is what I really need to know. It works. And I'm a sports guy. So I tell everyone, you're in charge of your cancer team. You're the general manager. My oncologist is the coach. And I decide who's on my team, whether that's friends or family. I have family members who aren't on my team. They're too negative. They give me too much negative energy. Anyone who's giving me negative energy, you're fired. I still love you, but you're not part of this circle. And what is that circle for me? It's that question. How you doing? I'm doing great. That's my answer every time. Doing really well. Except for my team. Certainly my doctor. They get the real answer because I might be doing crappy. But telling everyone around you that you don't feel like you need to open up to, you don't owe them anything, so to speak, telling them you're doing great starts to convince you you're doing great. And it's a mindset thing.
Yeah, that's a great way to articulate that. It's almost like manifesting your emotions, and I mean that's one of the principles of things like cognitive behavioral therapy is you can facilitate those kind of psychiatric pathways. If you're pushing positivity and you're finding the positive elements, the light and otherwise darkness, then I think that's what you end up seeing, and that ends up being your reality, even in something as challenging as cancer. Because the alternative is being surrounded by negativity, being surrounded by darkness, and it doesn't help you.
Yeah, I mean, even comments like, "Oh, that's you poor thing," or something like that. It's like, no, I just got to deal with this. I mean, I didn't do this to myself. Nobody did this to me. Life dropped this in my lap. I can complain, won't help. I can look backwards, it won't help. So let's just deal with it and try to attack the problem, which for me is a daily action. Let's have a good day, and let's put another good day together. And you're going to have your bad days where you just want to lay in bed and feel sorry for yourself. Take it, get over it, move on.
Well, and something you said where other people, that you poor thing, people expressing strong sympathy, but acknowledging the negative elements. What are the public perceptions about prostate cancer that you've experienced after being diagnosed?
It's not serious. I had a guy I was trying to do business with say, "Oh, good. At least you got the easy cancer. You can get over it and move on." I'm like, you don't understand what stage 4 is, do you? And prostate cancer, and Justin certainly can speak more about this, be more accurate on it. If you catch it stage 2 and below, you're fine. Even stage 3, if it never spread, you're fine. You got this little egg that is holding the cancer. You get rid of it. If that's the chosen treatment. Stage 4 means the cows are out of the barn and we got problems. And now they're hiding all over the place. Because my initial spread was my bladder. It is no longer in my bladder from my first radiation. But when I came out of remission 2 years ago, it's now in my lymphatic system, so it went metastatic on me. It just goes off and hides and then says, "Hey, I'm back. Let's have some fun." So that's just the reality of stage 4 metastatic prostate cancer is there's a very slim chance you're going to beat it. And if you do, you won't know it because it could still be lingering out there. And at age 70, if I make it there, hope I do, 61 now, it might come back and you're going, well, let's do this again.
Yeah, I think the perception that prostate cancer is not serious, it's one of those that you can just cut out and it's fine. I've heard that too. And there is that sentiment in the cancer community, patients, providers alike. Justin, can you speak to where that feeling comes from, where prostate cancer isn't serious?
Yeah, definitely. I think it may come from the fact that, the vast majority of men, when they're discovered to have prostate cancer, they have localized disease, which is considered to be curable. So I think that may be where it comes from. Most people when they're diagnosed or actually don't have symptoms like Fitz you had, it was just a screening. It was a PSA, which is just a protein that's made by prostate cells that was elevated, and then you go down the route of looking into that more. And so I think because of those two things, that most people are cured of their disease and are seemingly asymptomatic, it can make it seem like less than a serious thing. But I think a very important thing, especially for those patients who have localized disease that is curable, is just because you got rid of the cancer doesn't mean there aren't signs or aren't side effects from the treatment that you had that now you live with every day of your life.
Yep.
And I think that that's lost on a tremendous amount of people. And like Fitz said, sharing things about what's happening with urination, accidents, things like erectile dysfunction. These are things that people don't talk about.
You don't.
And they're not, comfortable coming forward about. And so if you had prostate cancer, you had your prostate removed, sometimes you have to wear diapers for the rest of your life. You have to wear pads. And that's, you're cured, congratulations, but you have that reminder every day. And so I think that some of those more hidden aspects of the cancer and actually the side effects of treatment, make it difficult for the public to really understand what a serious thing it can be.
Yeah, and I want to go into some of the side effects and treatments in a little bit, but you had mentioned the PSA, and that's it's a known acronym for a lot of people, and we associate that with prostate cancer. Can you speak a little bit to what the PSA is and how it's used to screen and or diagnose prostate cancer?
Yeah, absolutely. So PSA stands for prostate specific antigen. And it's a protein made by prostate cells, both those with cancer and those without. And it is one of our main screening tools to determine whether somebody may have prostate cancer. That which can be paired with something called a digital rectal exam, where physician or provider inserts a finger into the anus to feel the prostate gland itself. I see Fitz making a face. It's definitely warranted. It's a less than pleasant experience for my patients. But those two things together can be used to determine, is further workup or imaging or biopsy warranted to figure out, is this prostate cancer?
And Fitz, you had mentioned your PSA went up quickly.
Mhm.
You said it went up by a point within a week, and then this prompted further testing.
Right.
Did that testing lead directly to a prostate biopsy, or did other things happen?
No, it was a quick work. I mean, first of all, and humorous but actually good advice to other prostate cancer possible patients. When you meet your urologist, you shake his hand. Look at the size of his hands. My guy had the biggest damn hands. It's one of the greatest mistakes of my life. I switched doctors for it.
It's a male-dominated field. I found it's mostly guys in urology.
Yeah, and
bigger hands.
But I'm trying to think about how are men more comfortable to talk about this with a woman or a man? How are we wired for this? Because we can't get guys to talk about this. I'm shameless. I'll talk about anything. Everything's fodder for humor for me, even if it's wet in my pants and can't get an erection. So I'm just out here doing that. But that PSA score was a 5.5 on one insurance lab. 2 weeks later, another lab came, but the same lab came out for another insurance company, and it had gone to 6.4 in 2 weeks. Nobody notified me of the 5.5. They gave me the lab results. Guys, I didn't know what a PSA score was. So what good does that do? And an agent from a national company called me from Florida and said, your PSA score is above 6. You need to get to a doctor. A PSA score is kind of still a controversial topic. It shouldn't be. You still got older doctors who worked during the phase of stop doing PSA scores. They're not accurate, and people died. Yeah, there's false positives. That can scare the hell out of you. But that goes away when you find out it was false. The worst thing to happen is being positive and not knowing and just cruising through life, then you're dead. So I'm a big advocate for the PSA score, big advocate for early PSA testing at the very least to get a baseline score, because I didn't have one. Maybe my PSA, doc, you know this, maybe it was just high. But having those two scores that gave us the comparison. It's really not about your score. It's about where it's going, what's it doing, how fast is it doing it. And, mine was considered extreme velocity. It's going up very fast. And, that from as soon as doc did the rectal exam, he goes, yes, we got something here. And it wasn't very long before I was in getting the biopsy, which is really unpleasant. And that showed stage 3, not really involved on as much on one side as the other, but they're like core samples. Maybe you just missed it. And I think that's what happened, because when my new urologist, who did robotic surgery, is what I wanted, got into the field, he said it was so much worse than what we thought it was. He said it was just a really mean looking cancer, and it had crawled out and gone up into your bladder. And he goes, I knew I couldn't address that issue at this point, because at 353 pounds, you would be dead before I finished. So you just deal with it.
One of the things that I think would frighten me as someone who were being evaluated for prostate cancer, and something I've heard from other patients back when I was in a role as a primary care physician, is the prostate biopsy. Can you explain what the process of getting a biopsy of the prostate was like?
It's like having a doctor put a hole puncher inside of you, and it literally kind of just feels like it's poking a hole right in there to get that core sample. What was interesting for me is the one that hurt the most was an area that the doctor didn't think the cancer was in. It's really uncomfortable. It's a really strange sensation, but you got to have it. You do. And hopefully science will catch up and find a way to better do it. And it's certainly with imaging now being so much more advanced than just 2018, they can catch a lot of stuff with imaging.
Yeah. And I mean, what was the process, I guess, physically like? Like, did you go into the room? You were in a gown?
Mm-hmm.
Like, what would someone else expect if they're they're in the waiting room to get their prostate cancer biopsy? What is that process going to be like for them?
Yeah, it's, your typical doc thing. I think all men, if they've gone to the doctor, have had that, what happens. And really the only thing I remember about it is my running joke to sing Moon River when it happens. But it's just intrusive, it's uncomfortable both physically and emotionally, but you have to have it done.
Yeah, it seems you survived it just fine. It's something people do get through, so I want to reassure people who are hesitant, I suppose, to get one. Their PSA is high. They don't really want to get the recheck because they know it may lead to this procedure, which does involve getting a needle inserted into the prostate several times, and painful, of course, but one of those things that we just have to get through if you're going to diagnose something in a potentially curable stage.
Well, if you've got prostate cancer, it ain't going backwards. It's not going to start curing itself. It's only going to get worse. So that's one of my messages to men. Just get to the doctor. If you've got anything, like, this is my lesson. I had leakage. Did I go to the doctor? No. And just go to the doctor. And if you catch it early with a PSA score, you're golden. You might have some lifestyle changes, but you're not going to die from it. If you kick it down the road, you could very well end up causing your own demise. And it's something men really have to learn about. And I'm from Kansas. Half of the state is agriculture, more than that. And I deal with those tough old bird farmers that are still riding a tractor well into their 70s doing daily work. If they're having some incontinence, I got a field to take care of. I don't care. So it's a big obstacle in certain cultures. And as Justin can talk about, and this might be another topic, certainly in the African-American culture, going to the doctor is an issue, and there's might also be genetic variables that make them so much more susceptible to prostate cancer. And that's another message I try to spread is, guys, particularly if you're African-American, go to the doctor. Just go. Because if you've got any prostate cancer history in your family, which a lot of Black guys do, you need to be on top of this.
Yeah. And to your point, if it's something you catch early, this is potentially curable.
Very, yeah.
And I want to, delve into that a little bit. So Justin, from the physician perspective, we use a lot of staging and complicated metrics to talk about how much a cancer has spread. For prostate cancer, generally speaking, how is it staged?
So it's pretty unique, actually. So in some ways, it's like other cancers where there is a stage 1 through 4, and that staging is in part determined by what we call the TNM stage. So the T talking about the tumor itself, how much has it grown outside of the prostate? Is it invading or touching other organs like the bladder, the rectum? The N stage stands for nodes. Has it spread to any lymph nodes in the pelvis, which are just right beside the prostate or far away? And then the M stage stands for metastasis, which has it spread to more far away organs. That being said, we also do incorporate the PSA level, as well as something called the Gleason score. So the Gleason score is basically determined by looking at the tumor under a microscope. A pathologist looks at it and says, how much does it look like regular, non-cancerous prostate tissue? And all of those things together can help you figure out a risk stratification, and also helps with staging as well. For those of us that treat prostate cancer, we think about it not so much as the stage, but is it a localized disease, so just contained within the prostate? Is it locally advanced or regional risk disease, meaning it's starting to grow outside the prostate and touch other organs, or spread to those pelvic lymph nodes beside the prostate? Or is it really metastatic and going to the bones, the liver, the lungs, etc.?
I see. So it sounds like the prostate cancer is more staged in a pragmatic sense of, can you go after it and cure it, or can you not? And then, there's always an in-between where treatment has to be escalated in some way for localized stuff. Fitz, what was your general stage, or how advanced had your cancer gotten when you were initially diagnosed?
So I was initially stage 3 Gleason 7. And I'm trying to think of when that time frame would have been, because I took the earliest surgical date available, which was July 3rd of 2018. So I think that was probably in June at some point where they finally came up with that or shared it with me. And as I said, once the doctor got in the field, he realized we've got stage 4 because it's out and it's spread. Luckily, it wasn't metastatic because it just went into my bladder, which sucks. There was discussion of removing the bladder, which now there's other options. But it was really aggressive, and it was on the move. And if I had taken a later surgical date, even 2 weeks, who knows where I'd be right now? And it may not be here.
So was all of the disease localized to the pelvic region?
Yeah. My lymphatic spread was behind my stomach, between my lungs and in my neck, mostly behind my stomach. So I did radiation. I've done 2 rounds of radiation, roughly 60 treatments, which is more than what they want to do. But when it irradiated my stomach, it took away my appetite, made me nauseous for about 3 months, which led to some great adjustment of eating habits and weight loss. So you got to find your positives out of these things.
So when you were first diagnosed, what was the full treatment recommendation for you?
Well, certainly get it out as soon as possible. Remove the prostate, which, as Justin can elaborate on, comes with a lot of unwanted gifts. The double whammy, though, was the spread and the aggressive nature of it meant by September, maybe, I was in radiation. October, certainly. You need a good 6 months to heal from that surgery for your nerves to recover and some of those kind of relearning things, and never got that. So the radiation fried every nerve that, they'd salvage a nerve, but immediately the incontinence greatly increased, erectile dysfunction, which I hadn't had a full erection in many years. Should have been another sign. That was another thing. I was never fully erect for many years. Again, thought it was obesity. But so we dove right into radiation. They hit it out of the park. They got it. But it's kind of carpet bombing in some ways. It's very precise, and yet it's not. I mean, there's a reason why the radiation techs leave the room. They're not standing next to you. So, you do get radiation other ways. And so I've had some ongoing bladder issues. It kind of, they're radiating your bladder. If you don't come in with a full bladder, which is really comfortable to lay there with, it can shrink it and harden it like a balloon. So I've had that, and then even some rectal issues with my lower intestine and not functioning as well as it should. Can't move stuff through. It's just a lot of things go on there. But we took, I just kind of went into observation after radiation, and 3 years of that, 1 year of remission, and almost a year to the date it came out in 2023.
Wow. So your treatment was surgery, radiation, nothing else.
No chemo, and I'm not sure I will do chemo. If I've got an incredible medical team, and if they recommend that, I'll have a deep dive into it, but I'm just not fully comfortable with chemo, and kind of what it does to your body.
Did they recommend chemo?
No, they have not. In fact, they have never brought it up to me. They've brought it up in the sense of, okay, you've had 2 rounds of radiation. We're done with that. We can't do that anymore. And then chemo might be the next recommendation if it comes back. We'll see. We're going to handle it. Just keep knocking it down whatever way we need to. And the reality is, and I was listening to a lot of stuff when President Biden announced he had this, and one of the realities of stage 4 metastatic prostate cancer is it's considered terminal, and you just got to deal with it.
Yeah, and you had mentioned that you underwent the surgery, the radiation, and we'll see what happens next. And it's been a couple years now. What are you doing for ongoing monitoring?
Just had an oncology appointment yesterday, telehealth, luckily, because I'm in Manhattan, Kansas, the other Manhattan, and it's a little apple. And my doctor's in Kansas City, University of Kansas Medical System. I cover Kansas State. It's a little uncomfortable, but they still want to save me. It's really interesting. It's an incredible facility, incredible team, incredible doctor. She's my second, or actually technically third oncologist I've had. My first one was awesome, and he moved on, went back into teaching in Rochester, New York. And I had another one that was kind of seeing me through into remission. And then when it came back, I wanted to go back to an oncologist that specializes in prostate cancer. And how do you make that decision? If you know doctors, ask them who they would go to. That's how I've got a buddy who's a surgeon. I said, who's the best surgeon for robotic taking out my prostate? And he told me Philippe Rosso. There's no one else. So that's my urologist to this day. And he has helped connect me to every one of he knows me. He knows what I need, what I want from my medical team. And he's connected me with incredible, talented physicians.
And this was caught with ongoing scans, PSA checks. Mm-hmm. What were they doing?
It was just those PSA scores were the entire indicator. And, I'm kind of a person now that's become more religious. And I certainly see the act of me trying to get insurance leading to catching my cancer as not ironic, because that was what my dad did for a living. He was an insurance man. When I received the call from, shout out to SelectQuote, some guy in Orlando named John took the time to call me and probably saved my life. I was covering the NCAA tournament Sweet 16 in Atlanta. And that's a great call to get, and then try to go focus on covering basketball. See, it puts a lot of perspective there, doesn't it? But in another strange twist, one of my good friends that I knew had prostate cancer earlier than me, he had it at like 51, lives in Atlanta. It was incredible. So the next night I'm in a bar with him talking about, and there goes my journey. I've started my journey.
Yeah, I think I'm also a religious person, and balancing the kind of the theology and cancer that's a tough one, because there's a lot of things that are unfair about cancer, and we try to look at our lives through a scope of greater meaning. And when something has extreme suffering without an ability to grow from that, I can struggle sometimes in putting that into a religious perspective.
Let me just say this. I'm very cognitive of people aren't as religious as others. And so I explain them to this way. I've had just prayer warriors all over the country. It's been amazing. Because I'm a public figure too, and that helps. And I'm a big believer in prayer, but I'll also take your positive vibes. If you don't believe in prayer, just send me some good thoughts. I think it's the same thing. But that is something they can do. I'm eventually going to sit down and write my book. It will be called Cancer Hates Joy. And one of my doctors along the way said, I have never had a patient beat the odds with a bad attitude. That stuck with me. Every one of them keeps a smile on their face, makes light of it, is open about it, and they hunker down and defeat it, but they do it with a smile. Because cancer really does hate joy. I really believe, getting back to the religion, that is the devil's work. It's a demon, and you handle demons with positivity.
Yeah, it's interesting, and a lot of my work is in the research realm, and those subjective elements
Right.
are something we don't,
How would you?
We don't know how to evaluate that.
Yeah, I mean, there's nothing scientific about anything of that in our current state of science. So it is a little bit odd, but I always come back to this. Even if you don't believe that works, it's a better way to live. It's so much better.
Yeah, I've found that too. Is I have had this framing where our role in medicine is to give you the longest number of high quality years. That's my role as a doctor, and medicine has for a long time focused really hard on the longest quantity element, but the highest quality element, we struggle there. It's harder to study it. It's individualized, but at least for me, with me and my religion, my quality of life is high in negative circumstances, and I found that in other folks too, as they get peace of mind and they feel a sense of peace.
That, you know what,
But
that might be a big reason why I'm not a fan of chemo. Then I think it cuts down on your quality of life. That was a great way to explain my hesitancy about chemotherapy.
Yeah, to that point, I think that is a really strong conversation to have with the healthcare team and your providers to say, hey, this is what's important to me. This is what I want to do. If chemo stops you from doing it, it's not the right call.
Yeah.
If whatever therapy is posed stops you from the things that you need to do to be you, and you need to find joy in your life, then that therapy, no matter how effective it may be, you really need to weigh those trade-offs. If they're temporary, that's one thing. But a lot of times chemo, particularly for metastatic patients, is a continuous thing. At least some elements of it are usually continuous. And yeah, those are really important conversations to have. And I think you hit on something that a lot of people also fear, is that if I sign up for this, my quality of life is going to go down a lot. But there's always the off switch. There's always saying, yeah, that didn't feel very good. I don't want to do that anymore. And people usually recover.
I'm not afraid of losing my hair. So that's an upside to it.
You're ahead of the curve there. Yeah, although you may lose your beard hair. I don't know if that's important.
To turn off your testosterone, that's a dandy. There's so many side effects, but when all your body hair starts disappearing, it's a little unsettling. Like, what happened here? There's so many little things that go on during the journey.
Well, and getting back to some of the treatment related, stuff, like going back to Justin here, what are the types of treatments that are offered for prostate cancer at different stages?
Yeah, so main three are going to be surgery, and that's for the disease in prostate cancer that's limited to the prostate or to the pelvis itself. Radiation, which can either be more generalized or focused. And that can really be used at all stages of the disease, but with a different goal. Sometimes for localized prostate cancer, you can just get radiation. Whereas for patients who have metastatic disease, if they're having, a painful area in their body, say they have a metastasis in their arm bone, and they just can't, the treatment's not helping it, having radiation to that area can be really helpful. In terms of what I deal with most, which is systemic therapy, meaning treatment that goes everywhere in the body, is the hormonal therapy. And Fitz, you touched on it, that it can be really tough to deal with. And I agree that some of my patients really have a tough time with it. And what it is it is trying to deprive your body of testosterone. It's called ADT, androgen deprivation therapy. Testosterone is a type of androgen. And we do that through either pills or injections. And the side effects can be very debilitating for some men. And I think one of the hardest parts is we don't have a good way of predicting who's going to have any side effects, who's going to have all the side effects. And so that can be challenging. In general, if somebody already has a poor quality of life, they're at an advanced stage, in general, we think they're going to do poor with the ADT. But even some young men can really struggle with it. And it's because it affects so many different things. And Fitz, it's great that you brought up that kind of little detail of you losing your hair, because I think when a lot of men are told about ADT, they don't get the full picture. I see a lot of men as second or third consultations, and they say, I wish somebody would have told me about the side effect. Shrinkage of the penis is something that happens too. And oh my God, you could wake up one morning and be like, is this getting smaller? And
Yes.
my doctor never told me about this. And is it in my head? And so I'm very careful to go through the list. It can be a really scary thing. Yeah. I go through everything, how their body's going to change inside and out, things that they can appreciate and that they can't appreciate. And I think, another important aspect of when counseling patients about ADT is that those symptoms stay with you as long as your testosterone is low. And some men, a small subset, never regain normal levels of testosterone.
I'm fighting right now.
You can be stuck. You can be stuck with that forever. And that is a risk that comes with depending on the type of treatment you get, injection versus pill, and then how long. So that's another thing that comes up frequently for patients who've seen other providers and then come to me and then say, man, I had no idea that, just because my last injection's today, it doesn't mean that all of a sudden the switch gets turned on in 3 months. It can take months to years for the testosterone to come back. And again, in some patients, it never fully does come back. So those are really important questions to ask your doctor. How's this long-term, is this going to affect me in terms of the systemic therapy and hormonal therapy for prostate cancer?
Kyle, it's hard to explain when you're talking to men about prostate cancer. It's hard to explain the ramifications of turning off testosterone for a man, particularly an older man who's had this forever. Some of them are profound. Some of them are comical. I mean, my memory sucks now, which is, and I'm 18 months out of my last Lupron shot. I was on a 6-month cycle. And my testosterone still is not even close to recovered. It's ticked up just a little bit, but not enough to really notice. It really weakens you. My muscle mass a lot of my weight loss has been muscle mass. It's just a reality of it. But it's also a mental change. Boys, when you start getting hot flashes, you get more sympathetic to your wife now because you get hot flashes. Same thing. They've turned off the hormones, and for women, it's part of the aging process, and it comes along with it with prostate cancer. And this is my running joke. I live in a college town. I'm driving down a busy road, and there's this 2018, right, not long after my Lupron kicked in, and I see a young woman running with her dog, and I checked out her dog. I knew right then that I wasn't wired the same. My brain was doing different things. Some of that, man, was gone. And it's hard to adjust. And for me right now, the energy and the memory are my two biggest things. And we just started talking about maybe doing some hormone replacement therapy, which I'm hesitant to do. But on a day-to-day, it would help me. But, guys got to understand this. Testosterone or adding testosterone with treatments doesn't cause prostate cancer in any way. But if you have it, you're supercharging it. You're feeding it. And so when someone tells me they want to, get your PSA scored right now, just go do that before. A lot of doctors don't do it yet. And a lot of doctors aren't connecting all these dots. And in many ways, we're following the 40 years later, we're following 50 years later, we're following the same process that breast cancer went through with educating the medical community on a lot of this stuff and the best ways to go. I mean, mammograms were, no, we don't want to do a mammogram. Don't do a self-exam. And that's my job. And you still run into that sometimes with prostate cancer because we don't talk about it enough.
Yeah, and Justin, a question to you. We've struggled with this in all or many elements of cancer where there's a screening protocol of some sort. Is you have to balance who to screen and who to not screen. At some point there's an age cutoff. At some point there's a risk cutoff. Like we can't screen everyone for everything every day, so we have to make some sort of trade-off there. What are the trade-offs for prostate cancer screening in the medical community right now?
Um, I think you don't want to overdiagnose. You don't want to subject patients to testing that is, maybe going to cause them harm, like a prostate biopsy. I think that those are things you need to consider. Is this PSA or elevated PSA ever going to become a problem? Some men never need their prostate cancer treated. They have very early stage disease. So if you look at some of the statistics for prostate cancer, it looked, when the guidelines changed several years ago, depending on the different bodies that put out information and screening guidelines, it increased, how much prostate cancer we see. But in reality, you were seeing much earlier disease that you maybe never had to do anything about. So screening always needs to come with the discussion about what are we going to do with this information when we get it? What does it mean? And at every step of the way, really understanding the risks and benefits of every scan and every biopsy that you do. And so those are some of the nuances of the screening process.
So when you were mentioning the risk of overdiagnosing, I can imagine a lot of folks listening saying, there's no such thing as overdiagnosing. You either have it or you don't. Can you speak a little bit more to the nuance there? And I want to mention that prostate cancer is somewhat in a unique category of cancers in that many folks have really low grade disease that isn't going to cause problems.
Most.
So it adds a level of complexity that folks like me in the lung cancer sphere don't really have to navigate as much.
I think I would change maybe overdiagnosis, or rather a diagnosis that you're not going to do something about. And that's most applicable to men who are in advanced age. So the guidelines currently, which I don't necessarily agree with, say that after 70, you don't absolutely need to continue to get a screening PSA. It depends on other risk factors, other diseases, life expectancy. 70s are pretty young to me. My parents are 75, my dad's 75. And so I can't imagine somebody not screening him. But, an 85-year-old person with, kidney failure, heart failure, and other these medical problems, probably screening them for prostate cancer doesn't make much sense. So I think being careful about just sending these tests and looking for things and causing this anxiety when it's likely never going to cause them harm, and they're likely going to die with the prostate cancer and not from the prostate cancer.
Well, and I forget the statistic now, but there's a certain age at which if individuals undergo autopsies and we just evaluate their bodies, there's more men who will have prostate cancer at some area than not. Am I correct in remembering that stat?
Yes, you are. Again, something that you die with and not from.
Yeah, so many people, as they age into their 70s, 80s, 90s, develop focuses of prostate cancer that'll stay where it is. It's not going to cause problems. And you would only ever know because you looked. So by looking more, we have this trade-off of more people are getting prostate cancer biopsies, more people are getting workups, and that's what's the saying? There's no solutions, only trade-offs. So the trade-off there is a lot more workups, and the field is always struggling to find what is the balance of, and how do we best identify those high risk folks who are going to progress into something more serious, advanced stages. It's going to spread, and we don't have great tools for that. Fitz, what do you think about the balance? As we're saying, we don't want to overdiagnose and we don't want to screen too many people. That's a conversation we have very academically in cancer physician circles. And from the patient perspective, I always see it viewed very different. I frequently see it viewed very differently. Where do you think that balance of having more diagnoses versus not overly diagnosing people who aren't going to ever be diagnosed with, cancer that's going to be spreading, the problematic cancers? I'm not articulating it well, but
Well,
where do you think
let me
that
start with
balance lies?
this. If I didn't have cancer, if I was just chugging along, and I had lost the weight and I was healthier, I would expect to have a full life at 70 and 75. I think that barrier has moved so far back. And the medical community hasn't embraced that. It's like, this is when we're not going to save you. Well, a lot of men are going to make it to 90 if they're healthy and if you catch it. So I'm really against that. I'm offended by that. You're not of value now. You're 70. I have problems with that. But I think every man should have a score at 45. You don't even know you had it. Your doctor, you don't know what most of your blood test is for. I see stuff on my blood test results. I'm like, I have no idea what that does. I have no clue. And I'll go look. I'm like, oh, okay. They've been tested for that, but not the PSA score for older men. It's just one more box to check, a few more bucks. But there's probably downward pressure from insurance companies to hold some of that down too. So I don't know. I've told men to get aggressive. If you feel like you need a PSA score, demand it. And if your doctor will not do it and you believe you need one, fire them and go get another doctor. You're in charge of this. You are. And if you feel like the doctor, and I don't think asking for a PSA score at age 50 is in any way outlandish, or certainly even 45. Just give me a baseline score. Can I have a baseline score? So I know, because maybe I'm 1.5 now. We have no idea what my baseline was. Justin, I could have had a 4 when I was perfectly healthy. So PSA score is just, everyone's a little bit different. And having that so doctors can see where it travels to is really the key.
Yeah, one thing that speaks to your point is looking through the lens of the purpose of the medical establishment is to provide the longest amount of high quality life. Your subjective experience and your anxiety, think of how much money goes into lowering someone's anxiety through, seeing a therapist, seeing a psychiatrist, being on, chronic anxiety meds. And if people have a genuine concern about a cancer diagnosis, it's like the amount of money we spend on lowering anxiety through other ways versus, I think, appropriate reassurance, even if it's a little premature, even if it's a little bit outside the guidelines. I tend to fall probably where you fall to say lowering someone's anxiety for a couple of dollars probably makes financial sense in the kind of holistic view of what the purpose of the medical establishment is.
Yeah. And that's a question I've raised for myself and me communicating to men about PSA testing and the ramifications of having advanced prostate cancer. Am I causing undue anxiety in them? Maybe I am, but I always come back to the trade-off of that little bit of anxiety really didn't mean much if we caught it. So I don't know. Again, nobody wanted to talk about breast cancer in the 1980s. No one, particularly women. That cuts to who you are. You start talking about a penis, you start talking about reproductive abilities, erections, incontinence. Guys don't even want to think about any of that. And that's something I've been willing to say, no, guys, we got to have these conversations. I wear a diaper every day. I wasn't post-surgical. I was on pads and not much leakage post-surgical. After radiation, now it's every day. I have no chance at a natural erection. Sure, I can get injections, but pass, that's not for me. So yeah, I'm going to lay it all out there. And if I cause anxiety, I apologize. I'm trying to inform and educate.
Well, and the symptoms you're describing are the real symptoms that people experience from the archaic treatments that we have.
Mhm.
But you've also shown the flip side of that, where your life with these symptoms is still a good life.
Yeah. Oh yeah. Do you adjust? Absolutely. My lifestyle's different. And maybe I was benefited from having a pandemic show up that caused me to lose my lease on my office, and now I work from home. That's been a blessing. And so now my whole lifestyle is different. For 17 years, I had a very visible office in the college bar district. My office was my advertising, my billboard, and it worked. And I got older and moved out, went to a quieter place, and now I'm at home, and I absolutely love it. I thought I'd go insane. So not everything ahead of you is a bad thing. And another thing, this is the strangest, most irrational thing, Justin, and I'm sure you hear it sometimes from patients that come up with something. This is what they're worried about, really. The Foley bag. I did not want to walk around with a bag of urine. I did that at post-surgical for 2 weeks, the greatest 2 weeks of my life. I never once woke up in the night to go pee. My pee was just hanging on my nightstand, and I could empty it in the morning. Oh, I wish I could sleep through the night. I'm lucky to get 3 hours in a span before I have to get up to go urinate. So, and now it's not just a matter of holding it, because if you fail, you got a mess to clean up. So I've gotten pretty good about that.
Well, cheers to looking on the bright side. A little bit of other forward-facing optimism here. Justin, are there any new treatments or advances in the field that you're most excited about?
Yeah, so, AI is all the rage these days, and AI has now come to prostate cancer. And so the current FDA approval is with a test called Artera, and it basically takes a digitized photo of your pathology specimen from the prostate cancer. And for men with a subset of localized prostate cancer, it can tell you if you benefit or not from the ADT. And it's really amazing because this used to be something, a very difficult conversation and a long conversation, and it weighed heavily on patients, whether or not to get the ADT, because we couldn't predict who's going to benefit from it, and now I have a test that'll tell me with a high degree of certainty that you're not going to benefit from this. Let's not do it. And so I think, to the point of, yes, trying to get rid of something that is curable is definitely, we should absolutely go full force with that, but also think about the long-term repercussions of it. And is there any way possible that we can de-escalate to make quality of life in the short term and long term better?
Yeah, that's great. And we've seen AI integrated in so many different ways. It's nice to see AI integrated in a way that utilizes pathology specimens, because that's something that everyone has access to. If you were diagnosed with something,
Right.
and that something can, benefit from these technological advances. I'm predominantly in the laboratory. I'm doing laboratory experiments, and a lot of the stuff I do is pretty far away from, seeing a patient. And once it does see patients, it'll see patients through trials. People will have to go to big centers. So that's a technology or a field where there's a long time delay. And I think AI is really interesting in that we're having a relatively short time delay in the advancements to seeing the patients. And then when it does happen, it can see a lot of patients at once. You don't have to go to these big centers to benefit from some of these new resources. So I'm also really excited about just the broad scope of what AI is bringing to the table.
From a patient perspective, cutting down on that time, whether it's imaging or pathology, it's that wait. The way I've taken the test, I don't know the results. The fear for me was always the unknown. I remember the day I found out I had cancer. It was a good day because I knew what I was up against. Your mind goes to the worst places when when someone says cancer to you, and then you're waiting on test results. Well, they're not calling me because it's that bad, which is irrational again. But that is the biggest strain on many patients. So if imaging results using AI, apologies to all my friends in radiology. If that AI can read that instantaneously and shuffle those results directly to your oncologist, yeah, I'm in. And the pathology things are really cool. Anything that can shorten that window of the unknown is really good for a patient.
I think we're going to get there soon. I think we're going to get to the point where you'll have an AI read of a scan and an AI read of a biopsy or a pathology slide. And I think, there will be the caveat that this is not the formal
Right.
professional read, but it'll be correct 99% of the time. So I think we're going to probably get there in the next 5 years or so. At least someone will roll it out. Yeah, I think that'll be good. Because one, I do think it'll probably be pretty accurate. But one of the projects I work on is building a model with some of the AI collaborators that we have in our department. And it is challenging to build models that always work. You never know what the AI is reading, so it's they're complicated stuff. I think there will be a delay, but this stuff is really low hanging fruit, and it would, to your point, it would benefit the patient so much, because that preliminary data point that says, this is likely a cancer, that's a good something, rather than waiting 2 weeks.
Yeah.
Yeah, it equips someone with, the emotional and mental reserve that they're going to need to rally up to fight.
Yeah. One of the interesting things, and Justin, you probably know more about this. I just kind of saw the headline and thought, oh, hell no, I'm not doing that. That a patient just had robotic surgery done remotely. The doctor wasn't in the room, was online.
I saw this. It was somebody in Italy or Greece that was doing surgery in Korea, I believe, or maybe the other way around. I,
There's a level of trust
I
there I'm not at.
yeah, that's
That'd be a
yeah,
perfect
but
time to get the spinning doomsday thing, because that's exactly what it would be.
yeah.
Yeah, you're holding an artery, and then it just goes. It's probably
Well, I
fine.
was just happy the
Buffering.
robots didn't rise up against mankind on July 3rd, 2018, because I'd have been screwed. Just being in there with the robot, and my doctor, he couldn't have fought off that robot. He's not a very big guy.
That's why we have to be careful about the AI algorithms. Once we put them in the robots, she's like, who knows what's going to happen? Yeah. Okay, so kind of wrapping up here, we've gone through some of the ways that a prostate cancer is screened for, diagnosed, treatments. Fitz, you're in a position where you've undergone your treatment, you're in monitoring. What are some of the things that you do to maintain your health?
I have, losing muscle mass, losing a bunch of weight, even if wanted, it has effects on your body. And so being active has been a challenge. I've wrestled with getting the parking sticker, the handicap sticker, because walking like 300 feet, if you can't do that, I've been there, man. And aside from the fact I have a really bad knee that nobody really wants to replace if I'm going to be dead in a few years. So yeah, I mean, it's just kind of wrestling through it day by day. You form habits that alleviate the stressors, taping my knee, or I've been active in gardening, which is the strangest development in my life. That's more shocking than prostate cancer. But, so now I'm hauling mulch around and 40-pound bags of rock, try to rebuild some of that stamina so I'm able to do things. It is really hard to get yourself to go exercise when you feel like crap every day. You're tired, things hurt. It just seems like insurmountable. And some days walking down the stairs to my studio is a lot. So I tend to come down here and work, and then go up at the end of the day. I'm not traveling up and down, because you're always trying to conserve energy.
Do you found that pushing yourself to exercise, even when you're feeling really weak, has overall improved your endurance?
I don't know yet. I mean, I'm just kind of starting this new thing. I was really hoping my testosterone, I just had an oncology visit yesterday, and I was really hoping the testosterone was back, because I was feeling better. So now I'm just going to go with it. We'll see where this takes me. But Yeah, I mean, again, when you go from 353 to yesterday I was 261, um, you, you need to embrace that and make the most of it, because I wasn't going to lose weight without cancer. I'm confident of that. I was having too much fun drinking and eating burgers and doing all that kind of stuff.
Justin, what do you recommend for your patients to maintain their health and be most ready in the event of a recurrence?
Yeah, I mean, it's exercise. And if patients, you know, I have plenty of conversations like what Fitz just described, and they just feel like crap and they can't get their bodies moving. And so I start with something small. You know, if they live, you know, within walking distance of, you know, one of their favorite stores, or like even the grocery store, I say, try to get to the grocery store and back, and try to do that 3 times a week. People who are otherwise, you know, just taking mass transit are really not walking. And I think just setting those small goals, and I put it in my note, and I said, how many times a week are you going to go? What time? And just setting a plan for people just to get moving. You know, people have other medical problems. They have bad knees, they have bad hips, they have bad backs, and you have to work with people and meet them where they're at. And, you know, I have a patient who discovered aquatic therapy, and now he goes, you know, to the Y 2 3 days a week, and he couldn't stand to jog. He couldn't, you know, weightlifting was difficult, and aquatic therapy was a big change for him. So I think keeping at it, understanding that no matter how small progress is, it's still progress, and keeping your body in the best physical shape to really protect from the side effects of ADT, and in general, just fortifying yourself, can really best prepare for you for the side effects that you have, things that are coming next as well.
Yeah, I found it's one of the hardest things as a provider when the symptoms are weakness and fatigue, to tell someone that the solution is, exercise and strength training. It's like, do the thing that you are the least interested in doing right now, as much as you can. And even fits to your point of the parking sticker. It's something I usually am against,
Right.
unless there really is a kind of a physical handicap that prevents someone. But for fatigue reasons,
It is.
it's a tough one to navigate.
It's also,
Um,
for me, it feels like a surrender, a
yeah,
confirmation of I can't do this. But as a
Yeah.
sports journalist, media parking quite often isn't the best parking, and you might walk a half mile to get to a football stadium or more. There's University of Missouri. My walk would have been a mile and a half. I can't do that. My
jeez.
young guy who's in shape struggled with that because Columbia, Missouri's hilly. So it's yeah, you don't want to give in any way, and a parking sticker feels that way. But also when it's 0 degrees with wind chill of -20, and I'm walking 500 feet through a parking lot to get to a basketball arena, I'm thinking, yeah, I need to go get that sticker every time, but I just won't do it. I just can't do it.
Yeah, yeah, and you'll naturally, we're gonna calibrate ourselves to the most comfortable thing. That's usually what we'll do. If one has the parking sticker and they say, "Oh, I'm only going to use it when I really need it," they're going to find themselves needing it
That's what I
more.
tell myself. I'll just use it when I really have to walk. But you know damn well when I pull up to the grocery store and there's a spot in the
Yeah.
front, a fat old man's taking that one.
Well, and if you're, going into Costco and the parking garage or the parking lot's totally full, you're like, I'm not going to circle.
Oh,
Like, I think any person would naturally do that, and that's how habits are made. All right, Fitz, any advice you would give to someone who's been recently diagnosed with prostate cancer?
any cancer. Just take it one day at a time. Pick your team. Trust your team, because they're your selection, and keep going forward. Just keep going forward. Be the buffalo. That cliche. Buffalo walks into the storm, not away from it. And you just kind of have to build your mentality to be that way. Yeah, today's a bad day. I'm going to take that bad day. I'm going to own that bad day. But the next 4 days, I'm going to tell everyone I'm doing great and I'm going to feel better. Just keep going forward.
Justin, any last sentiments or messages you'd like to provide our listeners here?
Yeah, just impressing upon people that they are not alone. They are not alone, and there's so many different ways that they can get support for whatever they're going through. Whether that is in the shape of counseling from their doctor, is that a social worker, is that putting in touch with other men or people struggling with the same disease. There are so many people suffering in the same ways. Sometimes they just suffer in silence, and that's the worst way to suffer. And you can get so much from learning from other people's experiences, and it makes every aspect of it so much more bearable and can improve your quality of life.
Yeah, thank you for echoing that. And Fitz, the last thing before we log off, you direct your own podcast.
In fact,
tell us a little bit about that and where people can go to listen.
Well, the Life of Fitz podcast on podcast networks, it's a separate thing from my other actual sports one. But on YouTube, it is part of our GoPowerCat.com YouTube channel. So you can find that, but Life of Fitz isn't just my podcast name. That's my social media name. So if you're on X or Instagram or, anything that has a handle, that's it. You can message me or just tweet at me or X at me, whatever it is now. And I'll get back to you. I will talk to any man that needs help with prostate cancer. I don't care how busy I am. I'm going to find time for you. In football season, I'm really busy, and I have, counseled many people. If any cancer, you just want to know about that, message me, just reach out. Cause you need someone that has no skin in the game. I'm going to tell you exactly what my experiences were and what my advice would be.
Well, thanks for that. And I encourage anyone who does feel the need to reach out to do that. That's how we connected, was through X, and and those small quick connections that you often think don't go anywhere can lead to some pretty great things.
Yeah, and social media can be a great support system. There's a breast cancer survivor who has a X account called Thanks Cancer, and she does a brilliant job with it. And all cancer patients discuss those bad days, and I've made some friends through that. And you build your own network. I've got friends in Ireland and England and Canada, as well as the States, that are part of what I consider my support network.
Yeah. No, it's one of the great things about social media now. You've been active on it. Many of the people we've invited on the podcast and who I've reached out to through academic oncology, I think this is a new era where patients and providers are getting closer to a level, even intellectual playing field. Patients know a lot about their cancers now in a way that is totally new. And patients now have the ability to inform their providers about things that they may not know about. Many cancers are really unique. They might have particular mutations, or someone might have something rare. And then if that's the case, frequently the patient knows more about their cancer than a given oncologist, because their patient is the expert on the cancer they have. That's how it goes. And I think having the comfort to approach people through social media and kind of treat everyone like they're just a person. Everyone's trying their best. We're all just people trying to, meet our own goals and do good here. So I think it's a cool environment and that we're all on the same team. And thanks, Fitz, for living that, joining the podcast here. Absolutely. And all you do in your own work.
Absolutely. Anytime.
All right. Well, I think that wraps up today's episode. Thank you all for listening, and we will catch you next time. Thank you for joining us on this episode of Cracking Cancer. If you found this helpful, please like, subscribe, leave us a review, and visit crackingcancer.org for more information. Every dollar we earn goes directly to furthering the podcast and supporting vital cancer research. Because together, we can crack cancer.